Good evening, everyone. My name is Mervyn Morgan. I'm from the ITP Support Association. I'd like to thank you all for logging on tonight for the association's latest ITP patient meeting. Our support group meetings, either in person or virtual, have proved to be a huge success since we started them almost 2 years ago. We moved to the virtual environment at the very start of this pandemic. I must just add that tonight's meeting is the 50th support group meeting since they started in January 2019, and I must also add this is one of the best attended. Thank you. Tonight I would like to introduce our experts. Dr. Gerard Crotty from the Midland Regional Hospital. Dr. Crotty is also one of the ITP Support Association's medical advisors. In addition, we also have the expertise of Professor Adrian Newland, Chair of Trustees of the ITP Support Association. I would also like to introduce two stalwarts from the association, a senior patient mentor, Rhonda Anderson, and somebody many of you will know from our social media channels, Mr. Anthony Hurd. Both Rhonda and Anthony also contribute regularly to our quarterly magazine, The Platelet. In addition, I've got pleasure in welcoming Mr. Derek Elston, the Vice Chairman of the ITP Support Association. Derek is also another one of our patient mentors, and he will be here observing and also answering any questions. Thank you very much. Okay, the first question, got a question from Andy. He was diagnosed with chronic ITP in 2015, and after various failed medical solutions, including steroids and rituximab, Eltrombopag was offered as a second-line medication. Thankfully, it has worked ever since with a daily 25 micrograms tablet. Currently lives in the UK, but is planning to move to Ireland with his Irish wife and his children. However, he's concerned about medical costs, especially to keep him on Eltrombopag and the conduct of blood tests and appointments every 8 weeks. Gerard?
But as far as drug costs are concerned, it is capped at that relatively affordable level, and indeed for people who can't afford that, there are people on low incomes. There's a medical card which fully covers the drug costs other than a fairly nominal prescription fee. So even though you mightn't be able to find that drug on the scheme because it's prescribed in a slightly different way, it is covered.
Thank you very much, Gerard. Andy, are you on the line?
Hi there. Yes, I am. Thank you.
Did that answer your question okay for you? Yeah?
Yeah, very reassuring. Thank you.
Thanks very much, mate. Thank you. Right. Next question before I open it up. I've got one from Dale Gregory. I'm not responding to any medication and feel it may be because I have secondary ITP. My consultant says I have typical primary ITP. How can you tell? How can you be sure?
Well, secondary ITP is secondary to some other identified condition. So if you don't have another, if you have chronic lymphocytic leukemia, or you have systemic lupus, or you have some other condition associated with ITP, then it may be that the ITP is secondary to that primary condition. But if there isn't another diagnosis, then presumably it is primary ITP. So that's really how that diagnosis is established. The treatment of secondary ITP is not necessarily any different. The same range of treatments broadly works, but there are additional options to treat the primary cause and actually, but by doing so, alleviate the secondary ITP in some cases.
Okay, thank you very much.
I think Dale also mentioned, sorry if I could come in there, didn't Dale also mention that he was diagnosed having cyclical ITP? I think I picked that up.
Not in this one, no.
Oh, sorry, I must have misheard.
Yeah, not in this one, no. Okay. Unless you sent another email, not in this one.
No, I obviously misheard, but certainly even the majority of the secondary ITPs respond to the thrombopoietins. Obviously, it depends what dose they're pushed to, but the majority of them will, although they're not licensed for that, but for most secondary ITPs, there is this immune-based mechanism, and platelets not being produced very well, and so you do see the response to thrombopoietin in much the same way as you do to primary ITP.
Great stuff. Right. I've got a number of other questions here, but does anyone who's online at the moment want to ask a question? Okay, Kay. Yeah, you'll have to unmute it.
Yeah.
Thank you.
I was just diagnosed on the 19th of November with ITP, which they think was caused by me getting the flu vaccination at the end of October. The steroids didn't work for me, but I've been on Revelade since before Christmas, and it's certainly pushed my count up. The highest it's gone is 115. And the only problem I'm having with it is I am struggling to sleep. I know that this can be a side effect, but it's getting to sleep that's the problem. And then staying asleep because I'm wakening every couple of hours. Is this quite common? Will it ease off, or is this just one of the things that I have to put up with on the drug?
I mean, that's unusual, I have to say. Certainly just starting about the reaction to the flu vaccine, that is recognised. And people with ITP are more prone to have the count fall following a vaccination, and that's one of the questions we get a lot at the moment with the COVID vaccination. But even normal people will can have the platelet count becoming low following a vaccination. It's relatively unusual. It's about 10 in a million vaccinations will see that, but it's usually transient and usually relatively mild. So it doesn't drop a long way and comes up again within 2 to 3 months. So to have a prolonged low count tends to suggest you may have had an underlying ITP to start with that was actually exposed by the vaccination. That doesn't mean to say you shouldn't have the vaccine, because obviously, and again, I'm sure we'll come on to COVID at some stage in the next hour. It's a question of looking at the benefits of the vaccine against the potential risks of the vaccine, or risks of the infection that you're trying to protect against. In terms of sleeping badly, we often find that actually one of the complaints of patients who are on the treatments like Revelade is often fatigue. I mean, we see fatigue with ITP, but it's also mentioned with some of the treatments as well. Now, sometimes if you're overly fatigued, you can have trouble relaxing and falling into a normal sleep pattern, but we would normally expect that to settle and to come back to normal. I guess you've been on the treatment for a couple of months?
Yeah, I've been on it since the 22nd of December.
Yeah.
When I was on the steroids, I was just manic. I was just hyper all the time, and was waking up. You know, I had a better sleep, but I was waking up at like 3, 4, 5 in the morning, and I could have got up and cleaned my whole house at that point. But this is when I go to bed, I have to prop myself up because I feel like it's like a choking sensation. It's like my mouth's always quite dry with them. So I'd take water to bed, but it's not helping. And then it's the getting to sleep. I could be lying there 3 hours and I'm still wide awake.
Yeah.
Right,
the trouble is, the longer you...
Go on.
Yeah, sure, come in, Linda.
Go on, Rhonda.
Can I ask you, Kay, please, what time are you taking your steroids?
Well, I'm taking them just before I go to bed now, because the consultant asked me to try and do it that way rather than earlier in the evening. So it could be 11 o'clock at night. I'm trying to take them at the same time every night.
Yeah, well, when I was on steroids, and I was on a very high dose, probably a double dose to what I would have normally had, I took them in the morning. I think you do have to have them with food, don't you?
Yeah, that's the steroids, but
okay.
It's the Revelade I'm taking, so I'm not on the steroids now. So the Revelade I take last thing at night.
Yep, okay.
So I don't know if that's maybe not helping either, but I don't know.
We don't normally see that with Revelade. Doesn't normally have a direct impact on sleeping in the way that that steroids certainly do. So I would expect, you're nearly 2 months out from that now. I would expect that to settle, to be honest.
Right. Okay. Right. Thank you.
Hey, we've got a few questions coming up in the chat. one from Nicola and Nicole. My question, are people who have been diagnosed with ITP after having a flu vaccination or another vaccination in the past, are they now recommended to have the COVID vaccine or not? And when they are advised by their doctor not to have the flu vaccine, are they recommended to have the COVID vaccine or not? Whichever doctor wants to pick that up. So
it depends why the recommendation not to have the flu vaccine.
Yeah.
Just because you aren't recommended not to have one doesn't necessarily mean to say that you wouldn't have the other. It depends on the reasons for saying that. But certainly we would recommend both the flu vaccine and the COVID-19 vaccine for patients with ITP, although there is this risk of a low platelet count. And I'm sure Mervyn will correct me if I remember the figures incorrectly. We've been collecting the data from patients who've had the COVID vaccine, and of the nearly 100 who've reported to us now, 4 have had the counts come down, of which all but 1 were mild. The one that was serious dropped into single figures, but the count pre-vaccine was 26 to start with. So that's somewhere where someone who we would have been particularly careful in the first place. But of course, the risks of a low platelet count with COVID are about nearly a third. And a low platelet count with following a COVID infection is a pretty severe combination, and people get very ill with that. So certainly on balance, the low risk of a low platelet count following the COVID vaccine, the risks of that far out are much better than the risks of getting a low platelet count if you actually get the infection. So we would certainly recommend both. I mean, the main reasons for recommending the flu vaccine is that flu itself often leads to secondary bacterial infections, which are what are often serious and occasionally fatal following flu vaccines. And we have to remember that in a normal year, anything between 10 and 20,000 people will die of flu. Funnily enough, not this year, because I guess a lot of people have got COVID who otherwise have got flu, but certainly we recommend a flu vaccine and a COVID vaccine. But as I said, if you've been told not to have a flu vaccine, that would be something you'd need to discuss with the doctor to find out if they're recommending you don't have any vaccines. It depends why they made that recommendation.
Okay, the figures Adrian was just saying about, yes, we had 4 patients have reported from now almost 200 responses we've had in our survey. We've had 4 patients report the counts going down, but we've had 5 conversely where the platelet count has actually gone up. So which way does it go? I don't know. Strange one. So
you can explain the count going up because, of course, a lot of people will have a reaction post vaccination. It's usually a bit of a temperature, shivers, sore arm. That means you're having a reaction to the vaccine. Now, naively, I think if you're reacting to the vaccine, that means it must be working.
Yes,
but that sort of inflammatory reaction is what pushes the platelet count up, because that's what happens to a normal person who has some sort of inflammatory reaction. Platelet count goes up. So that's quite understandable in someone with ITP. But as you said, it's difficult to predict. But of course, the lower the count when you get a vaccine, even if it drops 10, that can drop it from a low level to an even lower level. But of course, if you've got a normal count, it drops 10, no one even knows about it. But a count of 50 and it drops to 40, you don't know about it, and it's not important. So it's a risk, but a small one.
There's another COVID-related question here. When getting the COVID vaccine, are we recommended to have a finer needle when it is administered? If so, how will we communicate this when we come under the general vaccination centre and our own GP? Because I know that I had a phone call yesterday. One lady who Adrian and I both know, I believe Adrian recommended that she should have a fine needle. When she went to the vaccination centre, they said, these are the only needles we got, this is what you're going to have. And they actually gave her the jab with the normal needle. So
it depends on your platelet count. Obviously, if someone with a low platelet count below 20 or 30, then we recommend a smaller needle. And indeed, if you read the inserts for the injections, they also comment on that. People on anticoagulation should have a fine needle. So I think it's a bit remiss of the centre not to be able to offer that. And certainly when I went and had mine, they discussed. I didn't say I was a doctor. I just thought I'd get on and pretend I was a normal person. But we discussed all those sort of issues, and I did notice they had an option on their desk. So, so they should have that. So the discussion with that should actually allow that to happen.
Yeah. Okay.
And if your count is low, the other issue is that you just need to press on the injection site for a bit longer. It probably no more than 5 minutes to stop excess.
Okay. Thank you, Adrian.
10 if you want to be on the safe side.
Yeah, we've got a question. Alice, you got your hand up? Just need to unmute, that's it.
Hello, thank you.
Hello. You can put your hand down now, Alice.
Yeah, still getting used to Zoom. Yeah, unfortunately, I'm one of the patients whose platelet counts did drop drastically. My count was 200. I'm normally in remission without treatment. I had a splenectomy 25 years ago. But I do have a history of my counts going down with the pneumovax and the flu jab. So that is a significant sort of pattern for me with vaccines. I was expecting it, and unfortunately it did happen. It went to 12 post my COVID vaccine, but it did go to 1. But I actually had COVID infection a year ago, and my count was 1 with a COVID infection. So I agree with you that the risk from the infection is likely to be worse than the risk from the vaccine. But my question was, I was wondering what you would think about my second jab, given that I have already had COVID itself, and I've had the first vaccination, and I'm in a low risk area. I'm thinking it might be sensible for me to delay my second vaccine, as that is likely to result in another low drop in platelets. And I did need hospitalization for this recent drop I had. I was just wondering what you thought.
It's interesting. The suggestion is that if you had the infection, probably one vaccination is sufficient, because it acts as a booster. Of course, if you had it a year ago, that may be less of a case, but I suspect that in the future, everyone will be having a COVID injection once a year, particularly those who may be in an at-risk group. But we don't know whether a single injection following a previous infection is sufficient. That's something that's being looked at. But certainly, if you had a low count following an infection and a low count following a vaccine, I think you would be. I think it would be not unreasonable to suggest either delaying your second vaccine or avoiding it. I mean, I think that's something you should discuss locally, but I wouldn't push you into having a second vaccine with that scenario. Gerard, do you want to comment on that?
Yeah, I would agree. We just don't have the data on how long immunity might last after natural infection followed by 1 dose of the vaccine. So for the vast majority of patients, I mean, and certainly in Ireland, we're not extending the gap between the vaccines. We're sticking to the licensed indication. In the UK, the gap has been extended out, I think, to 12 weeks, so that a lot more people can get the first dose in fairly quickly, and then catch up later with the second doses. But so for the majority of patients, if you get the first dose, even if you had COVID already, you should get the second dose when it's offered. But someone like Alice, who's had a particularly severe and it would seem fairly predictable drop given her previous experience, requiring admission, I think that would be one of the very few cases where delaying indefinitely at the moment where the second dose would be reasonable, at least until we have more information on the duration of immunity following the single dose of the vaccine.
It's worth saying that for the gap between the 2 injections, the Pfizer vaccination, they chose 3 weeks as their gap because they wanted to get the studies done very quickly. They didn't want to extend the gaps. But the Oxford AstraZeneca vaccine, they looked at a number of gaps, and actually by delaying the second booster vaccination for, I think it was up to 6 weeks, the response was actually better. Now, if you think about it, following the first injection, you're developing your immunity, and that immunity increases over the weeks. So if you're boosting that immunity, the more baseline immunity you've got, the better your secondary response is going to be. And so I had the Oxford AstraZeneca. I mean, I had no choice. That was what they offered me, but I feel quite comfortable with that. And I feel quite comfortable with having a gap of 10 to 12 weeks. So I wouldn't feel that you're getting a second best option by delaying the gap. And I think actually the results we've seen this week from some of the preliminary studies coming out of Scotland, where they followed 1 million people who had the vaccines, is that even following a single vaccine, both types of vaccine available in the UK were giving very high levels of response even after 1 dose. So I think it's quite encouraging. And of course, immunity doesn't disappear after 6 weeks or 8 weeks or 6 months. You always have that memory there. You may not be able to detect it, but what you're stimulating is the memory for infection. That's one of the reasons why you often don't have to, for those who get a splenectomy who had pneumovax, we don't consider repeating that for 5 years. And some people will still have some baseline immunity at 5 years if you study it. So I'm relatively relaxed about that longer gap.
Okay, Linda.
Hello there. I just wanted to ask, I haven't had my COVID vaccination yet, but I was wondering whether I should have my platelet count checked before and after, just to, keep track of it, or do you not think I should bother? My platelets are in the normal range on medication just now.
I wouldn't bother. If your count's normal, I wouldn't bother.
It
Okay.
very much depends. If someone has very unstable or brittle ITP where it's up and down to a big degree, then it would be reasonable to check a baseline shortly before the vaccine. Just as it needs to be checked probably reasonably regularly anyway in someone like that. But if it's stable and at a normal level, then I would agree, no need to do it.
Right, okay, magic. Thank you very much.
Thank you, Linda. We've got a question from Carrie in the chat. My 9-year-old son was diagnosed with ITP back in 2017. That year he had a skin rash and platelets were below 20. The last 3 years they've been low, albeit not as low as 20. We have blood tests every 3 months. His platelets vary between 60 and 110. We paid to see Dr. Delu Fontaine in London, as we felt as though there was a reluctance to address the issue of severe fatigue, very, very severe bruising, and a 9-year-old not being able to live a normal life. After seeing the doctor and they had a bone marrow aspiration, it was established the issue was most likely with his spleen. Is it standard practice not to treat or medicate children who have ITP on this scale?
Well, there has in the past been a tendency with children not to treat them on the basis that the majority spontaneously get better. About 2/3 of them do. But I have to say the latest ITP guidelines, and I don't treat children myself, but this is what the guidelines were saying, written by a number of our experts in the UK, led by John Granger, who's the paediatric haematologist in Manchester. And this is looking at what people's suggesting now on an international basis, is that they are treating children much more aggressively early on, and they're getting on to using the thrombopoetins. I think ramiprostim was the one that was used in the studies, but I suspect that either would be the same for those kids who don't respond quickly to steroids. And we keep the steroids as a very short, sharp dose, giving it for no longer than 6 weeks because of the side effects. And they can be particularly pronounced in kids. So Unless the count looks as if it's going up very quickly, then they would probably be given a short course of steroids. And if they responded fine, if they didn't, then they would push early and more aggressively with one of the thrombopoetins.
Okay, Gerard, anything to add on that?
Well, like Adrian, I don't treat children. So I think the issue here, though, is perhaps the tiredness more than the bruising. I think the platelet count 60 to over 100, which usually, unless there was some other bleeding problem, would not result in significant symptoms or any symptoms at all. So, but the fatigue is an issue in this case. So that can be tricky to deal with, because one of the questions, if the patient has a platelet count, and again this could be in an adult just as much as in a child, a platelet count that is more than adequate, do they need treatment? And you know, they have to weigh up the side effects of any treatment versus the benefits of that treatment.
Okay, thank you, Gerard. Got a question here from Katie. Katie plays sports. She's a member of a Mother and Others GAA football team. Should patients diagnosed with ITP be involved in contact sports and sports where they may end up clashing with others? We had a question similar to this, I believe, thinking back in the Dublin meeting a couple of years ago. When she was first diagnosed, her count was 7. She's now stable between 250 and 280. Is she okay to play a contact sport? Gerard?
Gerard.
Yeah, I mean, she's got a normal platelet count now. Obviously, it'd probably be good to establish that is stable in that range. You know, it doesn't have to be as tight as that, but stable at a reason, at normal or close to normal levels would. Once it's above, you know, for contact sports in general, once it's above 50, you're into reasonably safe territory. You know, and certainly if it's in the normal range, that's very safe. I suppose the worry might be if a relapse had occurred and it wasn't known about, and the person had some trauma. I suppose that is a slight risk. But I mean, you know, in general, it has to be an individual decision, because obviously if someone has very severe ITP with very frequent low platelet counts, then contact sports will probably be inadvisable in that sort of situation.
Okay, thank you, Gerard. Katie, was that okay? I can see you there. You was nodding away to that thumbs up. Good stuff.
I once looked after a midfield enforcer for a championship league football player, and he ran counts of about 80, and I have to say he used to get the odd bruise because he was an enforcer, but generally managed fine. So certainly I think Katie can do whatever she wants.
Thank you.
Good stuff. And Katie's also asked another question, which a couple of people have actually asked, and this was a question that come up at one of our last meetings. Vitamin D, Rhonda and Anthony. My vitamin D level is quite low, so I'm interested to hear about what role does vitamin D play in maintaining a healthy immune system and strong bones, especially for someone who's been on steroids. Is it important to take a vitamin D supplement when you have ITP? This has come up loads and loads of times. So I'll ask our mentors on this one, first of all, Adrian and Gerard, and then
Sure.
Rhonda?
Well, I do take vitamin D supplement, because once when I had a blood test, I had sort of some symptoms of vitamin D deficiency, such as aches and pains and things like that. So when my blood test came back, I was low in vitamin D. So I do take a supplement. And because we live in the Northern Hemisphere, we don't get the benefit of vitamin D from the sun. And vitamin D is added to food, I think, like bread and cereals and things like that. But if I don't eat those sorts of things, And I just think it's much easier to take a good supplement. I actually take a liquid one. I put 1 drop in a glass of water that I take my other tablets with at breakfast time. And also, if you've been on steroids, it's a good idea to check that you've got enough calcium, especially if you're a white, slim woman. And after the menopause, you want to be sure that you have got enough calcium and that you're not going to go into osteopenia or osteoporosis. So if you do have any backache or anything like that, might be an idea to see your doctor and see if you can have a DEXA scan to check if your bones are strong and so on. So it is important. And even now, I mean, the sun is shining a bit, but I think it's only between April and September that there is enough vitamin D from sunlight. And you do have to make an effort to go out into the sunlight. I mean, most of the time when I go out in the sunlight, even in the summer, unless it's a really hot summer, I'm mostly covered up because I'm Australian and I don't want to get sunburnt because I don't want to get skin cancer. So, you know, there is a very fine balance between getting the vitamin D, and so I think that most doctors would agree that most people in this country are probably vitamin D deficient, and it wouldn't hurt you, but don't overdo it.
I see that Anthony has actually got his box of vitamin D there. I would concur with Rhonda. Actually, I take vitamin D and my wife does as well. There's no direct evidence that it's helpful, but there's a lot of circumstantial evidence now that vitamin D is not only important for your bones, but it's actually important for maintaining your immune system. It's actually quite good for your bone marrow development as well. I mean, I did some work which I published on that 20 years ago now. So it's a very interesting vitamin, but as Rhonda says, at this time of year, we're all deficient. There's no doubt about that. Unless you play golf in a short sleeved shirt, which you'd be foolish if you did, we'll all be deficient. So on the basis that you can take it either in a liquid form or some very small tablets, they're very easy to swallow. You're not going to come into any problem. You're not going to take an overdose if you take, I think it's 100 international units or 25 micrograms a day. You can probably get by with 10, but 25 a day is more than enough. It's nowhere near a high enough level to cause problems, and it may benefit you. And there's certainly some reasonable suggestions from studies that people on vitamin D actually respond better if they get infected. But I think it's generally good for health. So I would concur. Clearly, Anthony knows that, and Rhonda takes it as well. So I think that's fine. Actually, I'll just add one thing. If people look at the chat, Anthony's put up the links to treating children with ITP that's on the association website, which is actually a very good thing. It's from John Granger, and it's worth people looking at who are interested in children with ITP.
There's just one thing I would like to add in terms of vitamin D. For those of us who are on the drug mycophenolate mofetil, one of the potential side effects of being on that drug is possibly, in very rare cases, developing skin cancers. So getting too much sun for people like us is dangerous. Even when there is some sun outside, we have to be very cautious. So for me, it's absolutely vital that I take a vitamin D supplement to make sure I get all the vitamin D that I can without having to sit in too much sun because of the high risk that I might be getting involved with due to my mycophenolate treatment for the ITP. So everything that's been said about vitamin D already, I certainly thoroughly endorse. Well worth getting supplements. I think most pharmacies will have a version of them. These are Holland and Barrett. Boots do them, Superdrug do them, all the main supermarkets. And for £3 or £4, just pick up, I think these are 100 tablets. So it's well worth it.
I agree. I actually take vitamin D as well. And I think, you know, particularly this winter, there's probably more people deficient because we're staying longer indoors. We're not going on a winter sun holiday because we're not allowed to. And due to restrictions, I think people are, and we're also just becoming more aware of the risks of skin cancer and that sort of thing. So I think everyone here should probably be on some vitamin D supplement, and it is very good for your immune system. There is speculation that it may actually help your defense if you are unlucky enough to get COVID-19 infection, although some of the data on that is of poor quality. But in other words, it's not really certain that it does help, but it can't harm, and it certainly is good for your immune system in general.
Okay, any other questions from the room?
Oh, yes. Sorry, just carrying
Alice,
on. Hello, just carrying on from the vitamin D. I actually bought one which K2 as well. It's D3 and K2 because I believe that K2 is helpful with clotting and platelets. Is that the case?
Well, vitamin K you get from your diet. It's not, whereas vitamin D is found in your diet in fish, and then there's supplementation of certain foods. But the main source of vitamin D, if you weren't to take a supplement, would be sunshine. But vitamin K is particularly present in green vegetables. And if you have a good diet with plenty of greens, then you're highly unlikely to be deficient in vitamin K in most cases.
But you won't come to any harm on the sort of doses you get in those combination tablets.
Another question on a similar theme, but on the question of alternative remedies for ITP. Papaya leaf extract, aloe vera juice. I've never heard of any of these. Is it just sorcery, or is there any merit in some of these alternatives?
Can I say something on that one as well?
Go on, Rhonda.
Yeah, I think I've written an article on this because at one of the conventions this came up and people were asking, is there any food that you can eat or not eat that will cure your ITP, basically? And there is no evidence at all that anything will or won't do you any good. So the point that I would make is that if you eat a food that you feel doesn't agree with you, then cut it out of your diet for a short while and see if that makes any difference. There are certain foods that I don't eat because I find they disagree with my digestion. And if I have them, I find I have problems. But I'm a person who is extremely allergic to fish, and I do have other, what I would describe as food intolerances, which is a technical term. So if you have an allergy, that is life-threatening. If you have an intolerance, it's something that you eat, or that you, that you eat, that is not doing you any good. So for instance, I love chocolate, but chocolate doesn't love me. So I cannot eat chocolate, and especially not chocolate that's got nuts in it. So I have to look the other way, or I have to have a piece and suffer the consequences. So you will know yourself what foods agree with you or not, but they're not going to make any difference to your ITP because this has not been tested, it has not been researched. And I think that is really about everything we can say about it, really, unless anybody, the doctors, want to add, or I think Anthony wants to add.
If I could just add one point before Anthony comes in, if I could just add one point. We just had a last question here from Bonnie Brown, who talked about being on Vit D, Vit C and probiotics on Revelade, and the count didn't go up until she stopped these. Now, if she was continuing the probiotics, it's quite possible that they've got calcium-related product in, which stops you absorbing the Revelade. So if she's taking probiotics intermittently, then that could impact on how Revelade works. So I just make that point about that specific question, and maybe I'll hand over to Anthony there. I just thought I had to leap in when I saw that.
Thank you. I actually raised the question about these what I call snake oil treatments, because on so many of the social media forums, I've seen lots of people, for want of a better phrase, be ripped off, basically buying things, being talked into buying things that really we have no evidence whatsoever that they're going to do any good. In fact, we probably may find that most of them do more harm than good. So I raised that question because so many people have shown on the social media groups that they've fallen for these so-called treatments. I also, like Rhonda, I actually keep a food journal, a daily journal of everything I eat and drink. So I think that's very useful for all of us who have got autoimmune issues. It's quite a good thing to know what might or might not upset anything else that's going on or might go on with our system. So I think that's a really good thing. And just one other final point, if anyone has got spare time on their hands, which maybe quite a few of us might have now, there are a number of really very interesting, useful, beneficial courses on the Open University Future Learn site, which they offer free of charge, all by online courses, a whole range of course material, but lots of them are on food, nutrition, the immune system, and even talking about the mental health impact of being diagnosed with rare conditions, and also even right up to date with COVID-19 as well. So if people have got time on their hands, they're worth looking at. You can do as much or as little of them as you wish. They're completely free of charge. And you may or may not get quite a lot out of them. So I thoroughly recommend those if people would like to have a look.
Now, one of our American supporters who used to come over and speak a lot at the meetings, some of you may have come across him, Jim George, he, a few years ago, with one of his research fellows, they trawled through the literature trying to find evidence of anything of dietary influences on ITP. And they could find no convincing evidence that was published anywhere that any of these things helped. And the conclusion was, if you eat a normal diet and get the right sort of balance of greens and other things, then that's sufficient. The issue is that if you take too much of anything, that can have an impact. I did have a patient once who came in with a very low platelet count that we thought was ITP, and she'd in fact was taking seaweed supplements for some health issue. Now, seaweed has lots of iodine in it, and she was taking so much, this just stopped her platelet count from her bone marrow from working. And we stopped the supplements, and these were sort of little tablets with seaweed she got from one of these health shops, and her platelet count came up to normal. There was also a case, again, many years ago that we discussed through the association of a patient who was allergic to sesame seeds. In fact, these were sesame seeds on burgers that I think she got them from McDonald's or one of these places. I shouldn't say a name, I'd probably get sued for it, but she responded to nothing and was admitted to hospital to have her spleen out. And of course, she was in hospital for 2 or 3 days. And when they went to take her to surgery, her platelet count was completely normal. So of course they didn't do the surgery. And so they began thinking about that. And she did come up with the idea that she actually that her diet was different because she actually wasn't eating burgers every day. So they did a controlled test and she ate a burger and her platelet count plummeted. So again, I think Rhonda's idea and Anthony's of keeping a food diary to see if there's anything that upsets you. If you have a problem with that, don't if everything is completely normal. But if your count is very unstable, just look at what you're eating and decide if you're taking too much of one thing or you're taking something strange, and just consider it in that way.
Certainly, just to come in on the whole alternative therapy and supplements and various things that are being promoted as a possible treatment. I mean, you know, doctor, we're often asked about this. In fact, probably often patients are taking things and they don't ask. But when we're asked, you know, the issue is that really the reason these things are called alternative is that there is no evidence in most cases. So in fact, in many cases, you know, you're given, I might be given the name of our product in the clinic. It might be very hard to even establish what's in it, or if what's in the supplement is actually what's on the label at all. You know, I mean, some of these particularly herbal remedies may not even be the plant they claim to be on the label. So I would be very skeptical about the vast majority of these. Obviously, there are some plant-derived medicines. I mean, morphine is the most famous one that are very well-known and powerful medicines. But they then become medicine. They're subject to clinical trials and they're licensed as licensed medicines. And so, you know, I think you have to be, you know, quite skeptical about alternative therapies, because most of them have really no evidence to support them at all. And as Adrian has alluded, they can have side effects. I mean, when sometimes these are promoted on the basis that they're natural and therefore can't have side effects. That's not true at all. Natural substances, particularly if taken to excess, can of course have side effects. And there's no link between something being natural or synthetic and whether it's likely to have side effects or not.
Thank you very much, Gerard. Thank you. Couple of other questions here from Camilla. Is it possible that ITP can disappear in children after puberty? Don't know which guy wants to take.
ITP in children often does disappear. In fact, probably the majority of cases of ITP in children are acute ITP and disappear completely in many cases. Whether before puberty or could coincidentally be around the time of puberty. Whether hormonal changes influence that, remission of ITP, I'm not really clear. I mean, ITP in adults or post-puberty is different, is certainly in young adults is more frequent among women than men, and there is probably a hormonal influence on that. And in fact, a lot of autoimmune diseases are more common during the reproductive years in women than men. And I don't think we fully understand the full basis for that. And then later in life, it kind of evens out between the sexes again. But puberty is probably not the specific link in most cases, but most ITP in children does go away.
Okay. Another question from Camilla. Is there any new medication for ITP on the market or coming on the market soon?
Well, there's several. I mean, the new medication is a drug called fostamatinib that's been licensed by the EU and is being considered by NICE as we speak. Although the Scottish Medicines Committee have approved it for patients who've not responded to standard first and second line therapy. If they've failed thrombopoietin or can't take a thrombopoietin, then you can have it. I mean, NICE, I think, are reconsidering it again within the next 2 to 3 weeks, actually. There are one or two other, there's a new thrombopoietin called avatrombopag, which is very similar to L-trombopag, which is Revelade. The benefits of avatrombopag is it has no dietary restrictions, so you don't have to restrict, you don't have to avoid calcium-containing compounds or have a gap before and after taking the tablet when you're eating to make sure you absorb it properly. There are at least 2 other agents that are fairly advanced in trials that are really quite exciting, that have an immune-based effect, so they don't have the side effects of the immune suppressive treatments. Of course, the problem with these drugs now is that the thrombopoietins are so successful that from 10 or 15 years ago, where there were quite a lot of patients who didn't respond well to our standard treatment, that proportion is much smaller. So it's much harder to do studies with lots of patients in for these. But as I said, there are at least 2 different classes of drugs that are currently being looked at in studies that are really promising. And I suspect within the next couple of years will become available. So yes, ITP is a very interesting drug for companies to study in autoimmune disease, purely because if you respond, your platelet count goes up, and all you have to do is take a blood test to check it. So a lot of these companies with these drugs that treat autoimmune disease home in on ITP to start with, just because they can get an idea very quickly if it's going to work. So we actually benefit a lot from that, and certainly in the adult ITP registry, we have a lot of inquiries from companies who want to come and talk to us about how they can develop studies in the UK. Unfortunately, it's less so in children because you tend not to include children in studies, and you're seeing this from the COVID vaccines. They're only now starting to look at those studies because people are very reluctant to give, quite rightly, to give drugs that are not tried and tested to young children when they're developing. But yes, we do. It may not seem like it if you have ITP, but we are fortunate in the companies are very keen to find drugs that make it work, because if it works there, it's almost certainly it's going to work in a lot of other autoimmune diseases, some neurological diseases, some skin diseases in particular. So they like it.
Sorry, if there's a chance that you haven't reacted to L-thrombopag, would there be a very unlikely chance you'll react to the avotrombopag you're talking about?
No, I think, have you, because I was going to come on to, you had a question early on about if your platelet count is naught, should you have a COVID vaccine? That was you, was it, Deborah?
Yeah, yeah.
I mean, actually, just to deal with that, because I was going to suggest to Mervyn, we ought to answer that, because you've been sitting in the bottom right-hand corner of my screen, and I've been feeling guilty because we missed your question. If you
haven't missed age when it's next.
All right.
Carry on. Carry on.
If your count is naught, I'm afraid if it's really naught, then you shouldn't have the vaccination, I'm afraid, because you will have a bruise. There is a possibility, although, I mean, one of the suggestions is that you could have the injection subcutaneously. The COVID vaccination is given into the muscle, and that's what the companies recommend. But the suggestion is that if you can't have an intramuscular injection, you could actually have it under the skin and then press very hard on it. And that's something, again, is the point that we were discussing earlier about using a fine needle under the skin, and you'd get it. You wouldn't absorb it as well, but you'd still absorb it. You would have a reaction. It depends on the willingness of the people and their understanding. We're actually giving it to recognize that you have an issue, and they're going to do it slightly differently for you. So now the issue of whether you responded or not, we know that 40% of people who don't respond to L-thrombopag will respond to romiplastin. And if you just fail to respond, it's about that. If you stop taking L-thrombopag because you react or whatever, then your response is actually better. But if you've gone to full dose L-thrombopag and you've not responded, then it's worth trying one of the others. We don't know that about avotrombopag yet, but the studies that were done in the laboratory when they were looking at responses shows that avotrombopag is actually a much more potent agent than L-thrombopag. So
I just wanted, I've been
actually be a better response.
Sorry, yeah, I'd actually sent you a letter about this. It's my son, and he's 14, and he's been 0 basically since he's been diagnosed last June. And he's tried the L-thrombopag as far as 125 milligrams, and then we went with your suggestion to add in the prednisone as well, and he had very good reaction to it. So we were due to start the romiplastin tomorrow, but I got a call this evening from the hospital to say that they've never ever used it in the hospital before, and they haven't got permission, and they're having a meeting tomorrow, on Thursday, to see about it. So
do you come from Dublin, Deborah?
Yeah.
My secretary got a phone call from a paediatric haematologist in Dublin today wanting to speak to me. So it must be about your son. Okay, I'll give her a call tomorrow. I always get
know the whole story.
I get very wary when people phone me out of the blue. I always feel panicky and think I'm going to be accused of doing something wrong. But as I know the story, I'll give her a call.
Yeah, that's it. Yeah. So
Okay.
I'm just, I suppose we kind of putting our hope now in the romiplostin because, you know, we've tried the eltrombopag and the prednisone and the counts are still less than 5.
I would certainly, I mean, I'll speak to her, but I would recommend as well that she actually spoke to Dr. John Granger in Manchester because he's a paediatric doctor and he's actually led the paediatric studies in romiplostin and would be able to give her really chapter and verse about what the responses are and how it's used. And he's really very helpful and friendly, and I'm sure there wouldn't be an issue in him responding. Indeed, what I'll do, I'll try and speak to her tomorrow and I'll give her his contact details as well, which may be helpful.
Brilliant. Great.
Okay. Okay. Thank you, Adrian. Thank you. We've got a couple of questions left. One that which you touched on a short time ago, Adrian. Patricia would like to know about Revelade, which her doctor recommends, but would like to know what the pros and cons are of it.
Okay, Gerard, do you want to?
Well, Revelade is a trade name for eltrombopag. I don't use trade names myself. I think that's the trade name of it anyway. I just call it eltrombopag. We tend to use the generic name. And as Adrian alluded to earlier, I mean, whether you go for romiplostim or eltrombopag, which are the ones we have available, and maybe shortly we might have avatrombopag as well, avatrombopag, whatever way you want to pronounce it. These agents have very high response rates. So the pros, you know, I mean, they're not licensed as the first treatment you would use for ITP. You know, steroids or immunoglobulin are the first line treatment. So they come in, I mean, officially, according to the license, they come in quite a bit down the line. But in fact, we often go earlier than the license where you have someone with severe ITP that's not responding. But they, compared to other treatments for ITP, they have a very high response rates and they are very well tolerated. So for the majority of patients who need them, the pros definitely outweigh the cons. I mean, they are a very effective treatment for ITP. I mean, there are other options as well, so they have to be weighed up which one you would go for. They're not suppressing the immune system, they're stimulating the production of platelets. So they do work in a different way to many of the other immunosuppressive treatments, which actually, interestingly, you know, if you're approaching perhaps being offered the COVID vaccine, is another reason why you might go for one of those agents rather than the likes of rituximab, which would probably impair your response to a vaccine. If you get rituximab, it actually hangs around in the body for many months and depletes the B lymphocytes in your body. So it, in theory, and probably to some degree in practice, would impair the response to a vaccine. So if you're looking forward to receiving the COVID vaccine, you'd probably, you know, go for one of the agents that stimulates the production of platelets rather than an agent such as rituximab that has a long-lasting effect in suppressing antibody production.
Okay, thank you, Gerard.
On the question about the new drugs, just on the situation in the Republic of Ireland, I haven't heard that the manufacturers of fostamatinib have applied for reimbursement. Now, maybe it's happening behind the scenes and I haven't heard. In terms of avatrombopag, I say, I don't know which way you're supposed to pronounce it. The manufacturers are beginning the process, and of course that is in the same category of, you know, it's similar class of drug to eltrombopag, as the name suggests, and it may be relatively easier to get it through the reimbursement process if it's an alternative to eltrombopag, which it would be in most patients. The additional cost might be minimal, if any, compared to eltrombopag. So that way, given that eltrombopag is already approved for funding in Ireland, getting avatrombopag through would be probably relatively straightforward, I would guess.
Thank you very much. Right, Libby, you just had your hand up.
Linked into that last answer, I was just wondering now that if we're going to have to learn to live with COVID long term, would that put eltrombopag further up do you stand a chance of being put on that quicker rather than going through the list of steroids and all those other immunosuppressants first? Would they put you on something that's a platelet producer more quickly?
Yeah, I think that's the case. That certainly it's been agreed within the last two weeks certainly in England that NICE have approved the thrombopoetins, either imiflastin or eltrombopag, for use much earlier in the disease, potentially even for those who are highly at risk without actually having received steroids at all. I mean, in general, if there's a low risk of COVID, and in someone who's not at high risk themselves, then we would recommend potentially a lower dose of steroids to start with, but with then going straight into a thrombopoetin, and the one you use depends on actually personal preference and your clinician's experience. But yeah, you're absolutely right, and that's one of the reasons why we pushed it with the authorities, with the regulatory authorities and the commissioners, that we felt we shouldn't be exposing people to immune suppression, because that's immune suppression in someone with ITP is what makes them at risk. It's not the ITP itself. It's not even having lost your spleen that puts you at risk. It's the immune suppressive drugs that we can give. So yeah, using the thrombopoetins much earlier on in the pathway, in the treatment pathway, is what we're aiming for. I think Mervyn has got the details, and I suspect we'll probably put it on our site. Will you, Mervyn?
I will, yes, I will, yeah. Got another question here from Nicole, just before we finish. Are there any newer meds safe or safer during pregnancy or when a woman is trying for a baby? On eltrombopag, her levels are 30 to 80, and IVG gives a terrible headache when she's tried it on 2 occasions in the past. So is there any newer meds that someone who's trying for a baby or is pregnant could actually
Well, the newer meds wouldn't be given to someone who is pregnant.
No. This is a big limitation with new drugs. They are not generally tested in pregnancy, and many medications being small molecules, they will cross the placenta, and so potentially could have adverse effects. So in general, these new medications are advised against. So we're very much reliant on steroids, immunoglobulin, possibly azathioprine, because it's been around for such a long time that it has been used in pregnancy and it is believed to be fairly safe. Most other medications are not advised during pregnancy.
Okay, thank you.
Just to sort of reiterate that point, but also for eltrombopag, and that's where we have most experience probably, it's something you wouldn't want to give while trying to become pregnant in the first trimester. But certainly we now have quite a bit of experience, although it's not licensed, in giving it to women in the last trimester, and in particular in the last couple of months, to actually get through delivery unscathed. And so certainly when the baby's developed at that stage, it has been used, and certainly hasn't seemed to get through into the baby to any sufficient degree to push the platelet count up to high levels, but it certainly makes delivery a lot safer in terms of potentially bleeding episodes.
Okay, thank you, Adrian. Nicole, does that help? Well, she's there, but she's not there. Okay, just one final question. And it's one of the questions we started off with Dale, just to go back to his original question. It is that nothing seems to be working so far when steroids did in the past, say like when he had a tooth out. His count is back down to 3 or 4. He's just stopped romiplostrin because it isn't working. He's now waiting for mycophenolates. Is this common with ITP? In that with some people, nothing can work. And, you know, this comes up all the time. I know Derek talked about this in one of his chats about how individualistic the condition is, and what works for one person doesn't work for someone else. So,
yeah, I mean, with the recently developed medicines, particularly the thrombopoietins, this is becoming less common a problem that a patient responds to nothing. But there still are a minority of patients who don't respond satisfactorily to any treatment. Probably quite a small number nowadays. But you know, you do have to be careful. And I think Derek, before spoke about having a, you know, and occasionally if nothing's working, I mean, you know, rather than having side effects from treatment that's not working, you might choose to be on no treatment if that situation is tolerated with you know, taking reasonable precautions against bleeding. But it is uncommon, and it's with and particularly with new medication, I mean, fostamatinib, then, you know, as a new medicine, as Adrian said, there's only a small number of people might need that sort of a treatment, but it does provide, you know, new medicines like that may provide options for people where all the other treatments to date aren't working.
When I read medication, Gerard, that's in the dim distant past, 20-something years ago. But it was an offer to come off all medication when I had a count of 10, which I did. And I lived quite happily for over 10 years with a count of 10, with the odd blip here and there. So it's quite possible, just need to be a little bit more careful.
Okay, any other questions? Sorry, Gerard, go on.
Less common nowadays because, you know, with the range of medicines we have now compared to 20 years ago, there's a much higher proportion of patients will find something that does work for them.
And I think Anthony makes that point in a response in the chat line as well.
Yes, he has, yeah.
Went on to the L-Thrombopac eventually. But interestingly enough, obviously my count went up when I came off that, dropped back down to 10. Then I had a heart bypass, and since then my count has gone up, and I've been at a very normal level until about 4 months ago when it dropped down to 50, which, okay, it's no problem, but it's a bit startling at the time, having been on 140 odd for so long. I think the answer is you don't panic. Take things in your stride and you look for advice from people that know. Like you and
you need to find a relaxed doctor, because doctors can convey anxiety to patients when often they don't need to.
Oh, some of them don't know anything about ITP.
That's true.
Certainly when I had a new young GP doing a blood test and my count was 10, within 2 hours he was on my doorstep wondering if I was still alive. So fortunately it was lunchtime, sat him down with a whiskey and we had a good chat. We went away a lot more relaxed.
And you want a doctor who's up to date as well. Certainly, going back, for instance, when I was a trainee, we over-treated ITP. There were patients who nowadays, you know, with a platelet count over 30 and not a lifestyle that puts them at particular risk of trauma, nowadays many such patients wouldn't need any additional treatment, and we were adding treatments to get the platelet count up towards normal, which is not really necessary. So, you know, we definitely over-treated ITP in the past, and, you know, you have to we have to be wary, particularly with immunosuppressive therapy. We could be doing as much harm as good, or more harm than good, by over-treating patients.
Okay, Anthony, you had your hand up?
Yeah, just if anyone has a bit of time again, if you have a look at the ITP Support Association,
Thank you, Anthony. Right, one last question, if anyone's got one. No hands up? Well, I'd just like to say thank you. I'd just like to say a big thank you to our two experts, Dr. Gerard Crotty and Professor Adrian Newland, and also the other people who spoke, Rhonda Anderson and Anthony Hurd and Derek, and everyone else for their contribution. I hope you found it useful. It's a marvellous turnout for our 50th meeting. Let's hope we have many, many more in the past. Hopefully, in the not too distant future, in person, in Ireland again. I look forward to it. And I see Henry Braid is there. So, Henry, we'll be speaking soon. So, thank you very much, everyone. Take care. Stay safe. Lots of love. Take care. Thank you. Bye-bye.